And welcome back. So now we're moving on to patient assessment part 2. So this is going to be a little different than the first section because we're going to be applying this in a little different way, but also similar to the last section. This will be different than the other lectures I do because I'm going to cover virtually every topic that's in here because it's that important. The challenge moving forward will be that as we go through every section, so let's say that we're assessing, or rather, I'm sorry, we're learning the cardiac block. When we get to the cardiac block or respiratory block, in each of these blocks, we're really going to apply the ABCs in the same way. The difference will be what our findings will be. So I'm going to kind of give you some of those things as we go, and there'll be that in your reading as well. When we talk about secondary, though, the secondary changes a little bit depending on your patient condition and a few other components. The primary doesn't. The primary assessment changed when we were talking about, is this medical or trauma? That's kind of it. Other than that, we do the same primary assessment for a cardiac patient as we will a respiratory patient, with some slight differences, very, very slight. Like, do I use lung sounds in the primary? That's going to be dependent on a few other factors. But for the most part, ABCs are always done the same way in our patients, regardless of the disease, because often that's how we figure out what their disease is. But once we gather some information, the secondary assessment is really going to be determined how we do it, when we do it, and what parts of it we do are going to be determined by a couple factors. So the patient's condition and situation are going to determine the rest of our patient assessment. So the first thing is to say that, remember, this is, again, kind of, I did this at the end of the last video, but let me do a more abbreviated version. We started with incident, right? 911, dispatch. We did our response and scene size up, windshield view, right? We did our doorway view. We did our primary assessment, and then we made a transport decision. Okay, so after we've made that transport decision, that kind of will spell out what we're doing. So if we decided that this patient is sick versus not sick, right? Our choices were sick is going to be load and go. Not sick, stay and play. So often when we're transporting patients, after a primary assessment identifies that they have some life threats, i.e. we have sick patients, then we're likely going to be doing all of our secondary assessment in the ambulance transporting. Some things we might do simultaneously as we're packaging the patient, getting them in the ambulance. But again, you don't want something to delay them from getting in the ambulance if our goal is to leave, right? That's kind of the whole purpose. But sometimes if we have a patient that doesn't have life threats, they're not sick at this moment, meaning life-threatening sick, then we might do our secondary and other assessments on scene. And certainly, eventually, we may transport that patient. So there'll be other assessments we do in transport. So be okay with the idea that it's going to be kind of fluid after your transport decision based on, is this a sick patient or is this a not sick patient, and we stay in play. All right. So as we manage and identify patients have life threats, we need to transport them as soon as possible. Again, this is to get them definitive care within an appropriate time period, minimizing scene time to less than 10 minutes in critical patients. As we move on, now after our primary assessment, we may need to do reassessments kind of interspersed with our secondary. So when I mention reassessment, though it's not listed here, reassessment, I want you to think of reassessment. When we reassess, you're basically reassessing your primary assessment. So it's a trick here that I want you to learn. It sounds maybe a little bit extra work, but it's very important that you learn to do this. So every time you reassess your patient, you always go back to whatever it is you were working with. So if it's medical, you're always going to go back and do your A, B, C, D, and E. And if it's trauma, you're going to always go back and do your X, A, B, C, D, and E. So what I mean by this is, when I did my primary assessment, I got my first airway assessment. I got my first GCS and LOC and AVPU. I got my first heart rate, maybe even lung sounds. And notice we mentioned blood pressure, maybe something we do a little bit later. So all of those things that I did in my primary assessment, my reassessment needs to include. Now the trick here is that if you learn to do a reassessment based on the patient's needs, then you're not going to have this built-in backup that you get if you use this reassessment style. So why I'm kind of mentioning this is because as you get into your scenarios, you might start your secondary assessment, but secondary assessment doesn't necessarily mean you're going to check the heart rate again. That's what a reassessment does. If the patient is sick, we may need to continue doing our reassessment of primary vital signs every 5 minutes or so. So you're going to have to kind of work that into your overall assessment. If you learn that every time you go back to do a reassessment, you always go back to your ABCs, even if you've done them before, the trick here is that if you get lost or mixed up in the middle of a scenario or on a call, because these are things that will be very stressful, emotional, a lot of working parts and things going on, it's hard to do even for an experienced provider, then you're going to want to be able to have a means of going back to center. So if you start your assessment and let's say that you're on the letter C, you know that you're doing an assessment, you just checked the heart rate and something happened, you're like, oh my gosh, what were the other findings? I didn't write them down. Or where am I? I can't, I got confused or lost. The patient asked questions, something happened, whatever. Don't start trying to figure out, okay, what was C again? Just go back to A and do it over. It takes seconds to do, and you'll make sure that you never miss a change in the patient's condition that's going to cause their condition to get worse in the sense of having A, B, C, D, and E. That's to say that if I just check a heart rate, I may miss the things that are going on with their breathing. That may be an indication early that I should do something. I might miss those until it's a big problem later and it's jumping out at me. So always in a scenario, if you get confused, no matter where you're at, always just go back to your ABCs or your XABC, D, and E. Just do ABCs again. That way, even if you did them previously, but maybe you missed something, you go back, you say, I'm thinking now, I'm focusing A, B, C, D, and E, do it all. You'll never miss those key components, okay? Because we don't want to miss those things. So reassessment, we're going to discuss a little bit more later, but I just want to mention that we still do the vital signs continuously. If they're sick, we want to reassess. Q means every, like as an interval. We want to reassess our patients every about 5 minutes. If the patient is that not sick, we're going to reassess them every 10 to 15 minutes. Okay. Sick patients get reassessed more frequently, and when I say reassess, we're always starting back again with our ABCs, doing them in total, so we have our vital signs to compare over time, and if we get lost, we just go back to our ABCs. All right, I'll remind us of that as we go. Now, history taking is I would say continued assessment. It's not necessarily our secondary assessment, and it is essential. So just as every patient gets a primary assessment, we need to make sure we get the basic history on every patient because it has the valuable information we need to learn about their medical history and to make sure that we're okay to give medications, either identifying indications or contraindications before we give them. So in addition to making sure every patient gets a primary assessment and every patient gets a basic history, remember that you should never give a medication without a primary assessment and a basic history. And we never give a medication without reassessing that patient after we've given the medication to determine how it's going. Okay, so that's in the back of your mind. You're thinking of these are kind of prerequisites to treat my patient. So when I say history taking, every patient will get a sample. Not every patient will get necessarily an OPQRST. We'll talk about that in just a minute. But the sample history is the basic requirement that goes with our primary. Often you'll find that we may be able to, especially in patients that either are not sick and we can and they're conscious and we can ask them questions, or if we do have bystanders on scene, we might be able to simultaneously do our primary assessment and start asking information about their sample history. Also, remember that you can delegate some of these tasks too. Early on as an EMT, we don't want you to delegate a lot of things because you still need to learn the skills of delegating as well. But in the field, if you have partners, by all means, use them. So if I'm the lead, I may want to be the one that does the sample history, and I'll be involved in kind of helping my partner remember and getting their feedback on their primary assessment findings if they do the assessment. So utilize the people you have that are on your team as well. If you're the team lead, they're there to help support you. All right, so what's the sample history? The sample history is a means of us memorizing an acronym that has individual letters that stand for essentially a subject that we're going to ask questions about. So what I want you to be able to do is memorize sample in total, memorize what each letter stands for, and then also be able to phrase a question based on what it is you're trying to gather. For example, it wouldn't be necessarily appropriate to ask a patient the term that we're looking for because it may be medical jargon. So you may have to change it into layman's terms to be able to ask them a question to get the information that each of these letters represents. Okay, and we'll define them in just a minute. OPQRST, this is another means of history taking, but we use this specifically for patients that have pain and or discomfort. Okay, if they don't have pain or discomfort, we often won't follow through asking all of these questions. Another tool that we can use as an acronym to help us determine a detailed physical exam, especially when we're looking at patients that have trauma, is DCAP-BTLS. So another acronym that has a letter that stands for each individual topic that we're assessing. And this basically tells us the type of injuries that we're looking for in medical terms. And then we also have our vital signs, which will probably be part of our reassessment. When we say detailed physical exam, this is probably leading to something like what I mentioned before, our head to toe exam. All right, let's start looking at this. So when assessing a patient's medical history, this is stuff that we want to hopefully get from our patient, right? That's our primary source of information. If we have to get it from anyone else, it may be spotty, or if they're a bystander, they may have no information whatsoever. So if our patient can't give us this information, try and seek it by either looking on the patient's body for medical alert tags, or again, things that they may carry on themselves or in their phone that have medical information if possible. So in addition to the questions we're going to ask, we also need to gather information for our reporting and just kind of the general legal and the billing components that we're not part of later, but it's really up to us to gather the information on scene. So some of the things that we need to have as part of our history, this will all lead to being charted, is obviously the date of the incident, not necessarily the date we're visiting them by itself, that certainly will be charted. But if this happened a different day, then we need to discern that. So ask patients, as we'll find later, we may ask patients about things that happened a few days ago to try and get to what's going on today. Anytime that we do an assessment or an intervention, we need to note the time and the findings. And so as we've talked about our primary assessment, when we do our primary assessment, we would write that time down on our chart and then write the findings for that time. When we do a reassessment, we'll write that time that we did the reassessment and we'll write down those findings as well. This also goes for treatments, medications, and so on. Patient's age, sex, race, past medical history, and current health status will be very important in demographic world for gathering a complete chart, but that information will be helpful for us in making decisions as well. The chief complaint, I like to put quotations around it to remind you that the chief complaint is what the patient says is going on, often is not actually the diagnosis or the actual thing that's going on. And when we chart it, the chief complaint needs to be as best you can in the patient's own words. There is one caveat to this. If the patient can't speak because their mentation is altered, then instead of writing a chief complaint, you can just write AMS, which stands for altered mental status. And that's to signify to the reader of your chart that when you leave stuff out, they assume you didn't do it. So it's to signify that I didn't include a chief complaint because the patient can't speak necessarily, and that's because of an altered mental status. All right, good stuff. So as you make your rapport with your patient, you introduce yourself, you shake their hand, fist bump, whatever it is that you do in the normal course of, you getting into communicating with the patient, we want to make them comfortable enough that they're going to give us this information as we ask for it. So ask a few simple open-ended questions, again, questions that will allow them to fill in the answers, not closed-end where we give them options or yes or no. Always refer to the patient as the name that they prefer to be called, but until you know that, Mr., Mrs., Miss, and then using the patient's last name will always be respectful until proven otherwise. So if they ask you to call you by the first name, then great, but don't assume that because some patients may be offended by it and you'll lose your rapport. I mentioned a little bit of this if the patient is unresponsive or if they have an altered mental status. We can ask family members about things. We can certainly check for medical alert tags and stuff that's on them. That's our medical alert jewelry here. And then if you're in the patient's home or in their patient's vehicle, there may be other clues there like medication bottles nearby and so on. Think about where medications might be too in a home, right? Where you keep them may be wherever, the majority of people keep them, but we may have to go into people's homes and investigate because they can't tell us where. So a few key places to look for things like medications and this information is sometimes they'll have some of their medical information, or a equipment like a BGL, blood glucose machine for their home testing of their blood sugar. That can have valuable information in it. Their medications may be in the medicine cabinet, maybe in the bathroom, could be in the patient's bedroom. We even find some medications have to be refrigerated. So checking the patient's refrigerator will be another place that'll be helpful to it. If you don't have people there that can tell you about the history, bystanders you may want to keep nearby until you're ready to question them because they may have information about what happened before you arrive that your patient can't tell you about that maybe they have witnessed. So it's not that bystanders aren't helpful. It's just that they may not know this patient. So the details beyond what they witnessed may not be helpful. All right, I actually am going to jump just out a slide for a second and we're going to start with sample. Every patient is going to get a sample history. So sample stands for, in your textbook, a few things, and I'm going to add things that you need to use and are also testable. So the S stands for signs and symptoms. So this is kind of just a reminder for you to ask the patient or gather the signs and symptoms from them in your assessment. If you haven't done so already, then figure out what the signs and symptoms are. They may not know what signs and symptoms mean, so that's what I mean by you having to try and think through how are you going to ask this question to get the best answer of the information you need from a layperson. In addition, though, signs and symptoms is nice, but I mean that's our assessment. So you're going to do that. So I want you to add another thing to this, and it's called social drugs. Every patient you need to assess for the use of social drugs, okay? It's not for judgment purposes by any means, and don't make them feel like you're judging. But when we say social drugs, these are things that patients may be taking that could be illicit, so it could be an illegal drug like cocaine or heroin. We need to know if they're taking those things, but it could also be legal things. So alcohol falls within social drugs, tobacco use, including vaporizing, not just cigarettes, cannabis use, all of those things we do need to know because they may be contributing to the disease or they may have an impact on the medications that we're giving. So how do you ask, a little old lady if she's taking social drugs? Well, the answer obviously is very carefully, right? So think of how you'll ask that. And again, remember that you may have to change the way you ask it for different patient populations. A for allergies. Allergies is asking if the patient is allergic to medication. So we're really looking for major allergies here to medications, foods like resulting in anaphylaxis, like their airway closed allergies. We're really not latex, another allergy that comes up. So we're not necessarily here looking for them to tell us about their seasonal allergies. If they do, put it in the medical history. But we're trying to determine, do they have something that they will be allergic to that we may give, right? So medication, latex, we don't use a whole lot of, but there are some pieces of equipment that have latex on it. So we want to make sure we're aware if the patient's allergic to latex before we start treating them, because this will have an impact on our treatment. Gather the allergies and ask what happens when they have that thing. Is it something that is mild or severe? There's a range of allergic types that we might find, and your best person to tell you that's going to be the patient. Ask about the patient's taking of medications. So ask them if they're taking any medications. Don't ask with closed-ended questions, are you taking these medications, and list them. Leave that for follow-up question later. Again, as I mentioned in communications, we want to start with open-ended questions and then narrow it down. Now, in addition to medications, we also want to know a few other things. So are they prescribed meds and are they taking them? Certainly people can be prescribed meds and not taking them. It's important we know that they're not taking them, but they have that prescription. Maybe you don't know what that medication is prescribed for. You never heard of it before. Ask the patient, why are you taking it? Because patients may be taking it under care of their physician for things that are that are not necessarily normal. So even if you do know what the drug's for, you may just ask what they're taking it for what we call off-label or black box prescriptions. That can be very helpful because sometimes you'll hear a drug that doesn't seem to fit with what you know about this drug in this patient, and asking about it will help tell you a little bit about why. So asking about prescription drugs, whether they take those drugs, right, we call that compliance. And then we want to know about other things like supplements and herbs. Okay, vitamins may be helpful, but all of these things are chemicals that the person puts into their body that may have an impact on their body, their physical condition, their body's response to disease and injury, and certainly interactions with drugs that we give. If you do ask about medications and they are taking medications, we're going to document those medications on their chart. And we're also going to want to note how much they take, like what's the dosage of it. And you can look at the pill bottle and determine, does it look like they've been taking them? So if this is a drug that has 90 pills in a bottle, it says total on the prescription, how much they were prescribed when they first picked it up. It'll tell you how often they should be taking it. So if it's 90 pills and they're supposed to be taking this 3 times a day, right, daily, that's basically a 1 month supply. So if you note the date of when it was taken, let's say it was taken 2 days ago, and you look at the bottle and it's almost empty, you know something's going on. Either those meds were taken, excessively. Could be a overdose attempt, could be an accidental ingestion. Maybe they're selling them. Whatever it is, get to the bottom of why those things don't line up. Often we find that there's more meds in the bottle in a lot of patients than it should be because they're missing doses. So kind of follow up with that. You may, when you go to the hospital, want to consider whether or not to take the medications with you. Sometimes, though, just know that in the process of taking the meds to the hospital, this doesn't generally happen on our end, but once we give the meds to the hospital may actually lose them. So kind of weigh that as to whether or not you should take the meds. Some patients need their meds and they'll take them while they're in the hospital in supervision. So a decision that you'll have to make nonetheless. The P is for the patient's pertinent past medical history. Pertinent means important to or relevant to what we're talking about. So let's give an example. If you have an 80-year-old male who is, you think, having a heart attack, and you ask about their medical history, pertinent medical history is going to be medical history that is at least one recent, so something that has an impact on their body now. Maybe it happened a long time ago, but it does still have an impact on their body. That's different than things that happened a long time ago that aren't really playing into the mix. So for example, if this person tells you, I had my tonsils removed when I was 10, that's 70 years ago, and they're potentially having a heart attack, the tonsillectomy may not be as important as other parts of their medical history. So we want to ask about pertinent past medical history. That will go in your chart, and often we might write it down as PMHX, HX for history, PM for past medical history. This can be helpful at telling you about the patient's current status and the things that they've experienced in the past as well. We ask about the patient's L, last oral intake and sample. Last oral intake is to tell us about the last stuff that they ate, maybe food, drink, whatever. So try and get a gist of what it was. We only really need these details if we think maybe they have a GI problem and they've eaten something recently. We may want to try and figure out what that food was. Maybe they're allergic, so they're having an allergic reaction, try and figure out what the food is. And then it could also be that we're asking this question in anticipation of them maybe having an airway issue. When a patient eats food and then shortly afterwards suffers a major thing to their body, so maybe they get in a car accident after they've eaten, the body likes to get rid of that stuff so that it doesn't have to process it. So if they've eaten recently, it may be a thing for you to consider, well, if they start getting nauseous and they've eaten recently, I'm going to have some vomit to deal with. And vomit can cause an airway issue. This is also helpful in determining that same idea of what's the patient's stomach status for their airway, but more related to us telling the surgeon if they're going to have surgery in the hospital. Okay. And then the events leading up to, you can use this as a segue of leading into a discussion on what's going on with them if you don't know this already. But at the very least, we'll kind of wrap up and summarize in our charting, for example, what the events leading up to the injury, the illness were. So if this patient was in a car accident, we'll kind of want to know what went on to the point of the car accident. Were they restrained? Did they have, what speed were they traveling? What type of impact was it? Those things help us kind of understand the thing we weren't there for, or the context of the situation we weren't there for, And that will be used kind of in conjunction with our physical assessment to determine what we think might be wrong with this patient right now in that presentation. The events leading up to often are going to go into something called the history of present illness, which is in the history section of your charting, but is describing basically all of the history stuff that's new, recent, relevant to their injury. All right, so a couple things about sample. You're going to ask every patient every one of these points every time. Okay, so every patient gets a sample history. I want you to memorize sample. I want you to memorize what each letter stands for. And when you practice this, I want you to always do it in order and completely. If you ask a question and they give you an answer, it may like naturally tend or lend itself to asking more questions about what they said, and relevant questions, I'm sure, for what you're trying to figure out. But use caution. Note those things and come back to them, because once you start following that line, you'll forget where you were in the sample order of questions. And when you forget, well, we start doing other things and we eventually don't do them. If you don't complete a sample, it'd be very hard for you to actually pass any scenarios. So it's an actual point that you ask sample, but all the information that we need you to get to understand what's wrong with this patient, that's from the sample. So not asking it and not asking all of it is going to rob you with some vital information that we intend for you to have to actually manage this call and pass the scenario. So in practicing, always ask it in order. Don't change the order for now. Wait until you're much later experienced, and always ask it completely before moving on to the other tangents. Okay. After we've asked those things, we can move on to the other tangents without risk of forgetting one of the sample questions. And again, a lot of this stuff is very relevant to determining whether or not we can give the patient a medication. Now I want to go back. So here's PQRSTU. Not every patient gets OPQRST in their assessment, but again, we're going to use this for pain and discomfort. So it's not just for pain. Somebody maybe doesn't feel well. This can help them elaborate so we can understand. So a lot of what we're looking at here is going to be symptomology, right? Symptoms are things that we can't see. They're not signs. They're things we can't see or observe ourselves. We rely on the patient telling us about them. So again, this is a great tool because without it, it's really hard to try and get to the heart of what the patient is experiencing. And so this provides an organized way. Again, we're going to ask this when we need to. So it's not always, but when we do ask it, we're going to ask it in order, the same way, and we're going to ask it completely. Again, when we're in a scenario, say a trauma scenario, if the patient has pain and you don't ask PQRSTU, you're going to lose almost 10 points right off the dot, because each of those things, each of these letters is an actual point. And that may mean that you don't pass that scenario. So again, you don't want to leave out some of these details. Now, because these are symptoms, right? These are things we can't physically observe. They're not signs. These often results are going to go into the history section, probably the history of present illness of your chart. Okay, so let's go through it. O is for onset. So again, learn the letter, learn the word it represents, and then figure out how you're going to ask these questions of actual patients. I'll give you a very good example in just a minute. So with onset, you're asking about what happened and when, what kind of was occurring when the pain started. So what was the onset of that pain? P stands for two things, provocation or palliation. So provocation means something that makes their pain worse, provokes their pain. Palliation, so palliation means like to relieve pain, to make feel better. And so the way you generally ask these two questions is, does anything make your pain better or worse? And note both things and ask both things. So if it's something that makes it worse, it's provocation. If it's something that makes it better, it's palliation. Those two questions by themselves, those 2 points by themselves, can help us determine whether or not we're dealing with one type of heart problem and another type of heart problem that we can't really get from other easily means of assessment. So just asking these questions is part of our finding out what's wrong. Quality. So here's a good example of how not to ask a question. So again, thinking of how to ask these questions beforehand will be a lot helpful to you. So if you ask a patient, What quality is your pain, right? They're in pain. They're probably not very excited about all of this. They don't feel well. And I don't know about you, but when you get in pain, often I tend to be a little bit short, especially in my answers to things. So instead of asking, what's the quality of your pain and getting a response, well, it's high quality, a-hole, right? Ask the question here for quality, what does it feel like? And let the patient fill in the blanks. Sometimes, though, patients are like, oh, that's hard to describe. Everyone sees these things differently. If you ask the open-ended question, what does it feel like? Can you tell me what this feels like? Excuse me. And they don't have any answers. They're like, what do you mean? You might give them some suggestions, but give them, a few suggestions so they don't just pick one and use that to try and fit what they're using. Again, going from open-ended to more choice-based closed-ended questions. So what are some of the things they may respond with? Well, maybe it feels like pressure. Maybe it feels like stabbing pain. Maybe it's sharp. Maybe it's throbbing, hot, burning, itchy. There's a wide variety of terms that they may use. Now, these terms should come from the patient. So when we're charting them, you're going to write that and you're going to quote what they said to make sure that the reader knows this is the patient's word for this disease or this pain. The region and radiation is one to identify where is your pain. So try and narrow it down to a region if you can. Ask the patient to point to where their pain is, so on and so forth. Again, you're going to use that wherever they point to say, okay, what organs are in that area based on your anatomy? And then radiation is to ask, does it go anywhere from here? Does it travel to another place from this point of origin? They may have pain in multiple areas, but that would be different than having pain in one spot that travels to another area. So with radiation, an answer might be, for example, a patient that's having maybe cardiac-based chest pain, they may say that they have pain in their chest that's radiating to their jaw or their shoulder. And again, we're going to learn diseases and injuries that have certain patterns of pain with them, and you'll use that in your memory banks to go with the patient's answers. Severity is try and get a scale going for this. Now, this is difficult. It's really hard to put pain into a scale, and it's really difficult for us to understand that scale because what I experience as being the worst pain in my life might be different than anyone else's experience. Maybe it's more, maybe it's less, maybe it's different. Those things really matter for the patient in the sense that we don't want to assume that their pain is anything different than our pain. And so the only way we can do that is to put everybody on a scale. So our scale, basically, let's just keep it easy. Sometimes the book says 1 to 10. I'm just going to say from 0 to 10. 0 would be no pain whatsoever. 10 is the worst pain. Don't go above 10. Let them choose a number on this scale. When they choose that number, you're going to quote the number. So let's say they say it's an 8 out of 10, and just document it as a fraction. Quote the 8 because they told you that out of 10 on your scale, and that becomes your severity. Timing. So ask them not just what was the onset, like what brought this on, but what was the time that this started? When did this start? So how long has it been going on? And note it. Now, a difference here between sample and OPQRSTU is that this becomes kind of like a vital sign. So we're going to want to reassess OPQRST. We're going to want to reassess this in patients, especially when we have treatment that's going to help address their pain. So I have a patient that maybe fractured their arm and they're complaining of throbbing and sharp pain in their arm, 8 out of 10. After I treat that patient and get their arm into a splint and relieve them having to hold it with their hand and let them relax a little bit, my goal is that the pain severity at least should go down and not up. So I have to reassess this after I do any treatment that's going to be associated with their pain. If my treatment's going to make their pain worse, I want to get an assessment of it. If it's going to make their pain better, I want to get an assessment of it. And maybe it doesn't make their pain worse or better, but I won't know until I basically assess it. So look at trending things like what is the severity of this pain now compared to other times. The region and radiation may change. The quality of the pain may change. And obviously, we may learn new things that make this worse or better in the process. So don't think of this as sample in the sense that we do this once and we gather the data, we can move on. This is something we're going to be reassessing. So I like to consider it basically like a vital sign. So those are components of the history. Those give us a really good framework to start asking the questions. So again, work on asking those as appropriate. Now, when we gather the data, right, we ask the question, they tell us the answers. We need to know what to do with those answers. Sometimes, those answers might be numbers, they might be words, whatever. It's all really data. We're taking this information in and we're trying to fit it to a picture that then tells us what all of these things mean globally for the patient. And eventually, hopefully, we can come up with a diagnosis or what we're going to treat. So in critical thinking is very helpful in this process as we try and make sure we're making the right decision, asking the right follow-up questions, and of course, making sure that we're giving obviously the right treatment that's not going to make their condition worse. So we're going to try and seek facts. That's really what we're after here. So that's the gathering phase. And then we're going to kind of evaluate the data that we have. So we want to think, but we're going to have to think on our feet with everybody looking at us. We're going to practice this in scenarios and start considering, what does all this information mean? Some information you're going to get isn't going to be helpful. And so don't be afraid to omit that information. We also use that idea for charting. Not everything needs to be charted. So critically think with the data you have, what's important, what's not, and what does it actually mean in the big picture. Synthesizing is putting it together in that big picture, basically putting it together and creating a plan for scene management and patient care. So we critically think all day on every call, basically, and our critical thinking needs to be pretty well organized. So one of the nice things about critical thinking to know is that when we're working on critical thinking, we're always actively receiving new data. So maybe I made a decision for patient care, okay, and I start executing that plan. In the middle of the plan, maybe I do a reassessment and I find, well, wait a second, something changed I didn't anticipate. Well, that would be gathering new data. I'm going to reevaluate that and I'm going to come up with a new plan. Okay, so part of critical thinking is to realize that it changes as you get more data and be flexible enough to change, because the worst thing you can do in managing patients is receive an important piece of information and then choose not to use it in determining what to do next. As we're taking the history, we want to make note of. So certainly we want to document this stuff in our chart, but I also want you to just think of making note of in your mind things like pertinent negatives and positives. So let me explain this. So pertinent generally means that it's relevant to what's going on. So pertinent positives and negatives are generally either signs or symptoms that we're going to learn to expect based on a disease. And those things are either present in our patient's description of their experience of it or they're absent. Okay, so I keep using the heart attack as an example through our stories here, so let's stick with that for now. Now notice it doesn't say the pertinent positives here, but there are positives and negatives. Okay, pretty easy to memorize the difference between the two. A pertinent positive is something that I expect to see here based on my learning about a disease, and I do see it. So it's important, I expect to see it, and I do see it. That's a pertinent positive, okay? If I expect to see it, but I don't see it in my patient, that's a pertinent negative, meaning it's important that it's negative. It's important that it's absent here for us. Some things, it won't be important if it's absent. So let me use an example. When we're talking about a heart attack, acute myocardial infarction, some of the things that I mentioned earlier that are involved in that become things we anticipate patients may experience. Not everyone's going to experience it, but it may be relevant that they're not experiencing it. So in an AMI, often we do find patients that say that when their chest is hurting, when they sit down from whatever activity they were doing, with a heart attack, it doesn't often go away when they sit down. So them resting doesn't make it better. But there's another disease called angina pectoris. We just call it angina for short, it means chest pain essentially. Angina pectoris is similar to a heart attack, but the difference between the two is that often with angina, when the patient sits down, the pain does go away. And so that's an important, both very concerning and lots more to learn about it. So let's say that I'm assessing my patient and I think that they either have a heart attack or angina. I'm at a point where I'm not sure yet and I'm still trying to distinguish that. So as I paint that picture and note in my head, if the patient says, while I was working in the yard, my chest started hurting, I came in and I sat down and the pain got better when I sat down. Okay, so that's something I would expect with angina, but not something I would expect with a heart attack. So it's important that I note that because it may be part of me making that decision. Another example of how I might use this when I get to one decision, let's say that I decide this is actually a heart attack, okay? When patients have heart attacks, sometimes they have something called a feeling of impending doom, in which they say, I feel like I'm going to die. I feel like something bad is going to happen. Again, we don't give the false reassurance of, no, nothing's going to happen. You're fine. That's not the way we're going with this. But instead, if they do have that feeling, then that would be a pertinent positive. I expect they're going to have that feeling. If they don't have that feeling, I might want to note patient denies feeling of impending doom. That would be a pertinent negative for this. So I expect it, but it's not here, it's a negative. So pertinent positives and negatives should be documented in your history section, generally under a history of present illness. But again, these are things you need to actively think about. Where will you learn these pertinent pieces of information that are either present and positive or absent and negative in our patients? Well, they're basically in the descriptions of signs and symptoms of every disease that we're going to go through for our emergencies, okay? So taking history on sensitive topics, we've kind of talked a little bit about that, but remember that patients may be uncomfortable physically, they may be mentally, emotionally uncomfortable, and so they've already got some things working against us. It makes it even more difficult if we add into the mix alcohol and drugs. And so knowing that patients that are using alcohol and drugs kind of changes our communication, but in order to determine whether or not they're using that, which could be relevant for our treatment or the disease itself, we need to, again, get these patients to have be on our side, to trust us, and we do that with rapport. Okay, so again, set the environment up the best you can to facilitate privacy so that they will start seeing that you are really thinking of, I don't want everyone to know this, I need to ask you this question. Now, invariably, there will be situations in which you're on a scene and you need to ask a patient a sensitive or private question. However, a family member is not leaving this patient's side, and probably because they mean well, though that's not always the case. So let's say that we have a patient that's underage, right? So they're under the age of 18, and you're asking questions during your assessment. Let's say they called 911, they have abdominal pain, it's a female patient. That female patient, if she's in the time period of having gone through the onset of puberty all the way up until menopause, that person is now potentially able to have a child if they have sexual intercourse. If a patient of childbearing years has abdominal pain, female patient of childbearing years has abdominal pain, we have to evaluate whether or not this is pregnancy or some other emergency that could be a life threat based on that. And one of the easiest ways for us to do that is to ascertain the patient's sexual activity and to determine some things about maybe their menstrual cycle and so on. So if I'm with a teenage young girl and her parents, and they've called 911 for abdominal pain, it may be that nobody on that scene, other than you, is thinking about the idea that this patient is within the realm of potentially, if having had intercourse, being pregnant. That may not be on their mind. It may be on the patient's mind, but not necessarily a family's mind. Just because the patient thinks that the family may not want to talk about that, or they don't want to get in trouble, or all the things that come from maybe them not being aware that this person is no longer a virgin, you're not going to get right answers out of this patient, truthful answers out of this patient if you ask them those questions in front of their parents. So it's not to say that you ask and then if they don't answer, you ask the parents to leave. No, the parents are going to know what you're asking about now, which embarrasses the patient even further. And so what do? Well, you kind of tactically find ways to allow your patient and you to have a private conversation without parents involved. And again, that may mean that you wait until you're in the ambulance to do so, but in some cases you may be able to ask or give tasks to family members to try and give you a little bit of breathing room so you can just ask those quick questions as necessary. And again, patient rapport is a big way of determining that. Certainly, a child's alcohol and drugs will be as scary, maybe more or less scary, but similar in stressfulness for the patient as determining the sexual intercourse if their parents find out as well. So we need to kind of be cautious in how we ask this. Also, if I ask about drugs and alcohol when a person is at work, they're probably not going to be honest if they've been intoxicated, because that's going to have an impact on their job if their boss or coworkers are standing by. So you can see the need for privacy is pretty expansive. During our history assessment, it's our obligation to make sure we're sensitive to signs of abuse or violence against patients. Okay. Now, certainly, abuse or violence against the patient could be a scene safety issue for us, especially if the person that's the abuser is physically there. They may, some people, may think that no one's going to know, but very often they know why we're asking certain questions. And so abusers are smart and they don't want to go to jail. And so if they're on to you asking certain questions or on to you picking up the abuse, it may actually mean that your life may be in danger, in the sense of, I'm not going to jail. And if you're the one that knows and you're not a cop, maybe I need to prevent you from telling the cops. So that's a reality that we have to face. Now, how we deal with the patients that are suffering physical abuse or violence is very, very difficult to describe, difficult to give you all the ins and outs of before you get into the field, but it's also extremely important that we do our best to get it right, okay? So anytime that we have a suspected case of physical abuse or domestic violence, we need to make sure that we report that. That may involve reporting that to PD, CYFD, especially for child cases. And then there's the Protective Services Division in the state for kind of like CYFD, but for older adult patients. So those are some of the areas that eventually need to be notified. If I call a law enforcement officer to a scene where someone I think is being abused, but I haven't seen it, all I have is the gut feeling often. That may not be wrong, but it's not often enough for us to chart on and document. So I may have other signs and symptoms that are showing it, but I didn't see the act happen. And the patient may be completely in denial to protect themselves from others finding out, because the abuser, if they know others find out, will probably take it out on the patient. So instead of calling law enforcement to this scene, which will probably make things worse without having us kind of get a better handle on the situation. Again, if the scene is unsafe or going that way, you call law enforcement for your safety. But if you call law enforcement and say, I think this person's being abused, law enforcement is going to confront the people that are there. And often there's enough denial involved in communication with the police officers, because again, the abuser doesn't want to get hurt worse when the person gets out of jail and comes back home. They'll often lie as well. And if the potential victim doesn't ask for help, then law enforcement can't really get involved. So that may just aggravate the scene and put basically the patient and the abuser against you. And so what you have to do is work with this within kind of the realm of what's going to get my patient the help most reliably. Calling a law enforcement officer may just make this worse. So it's not the most reliable unless the patient obviously is in imminent danger and your scene safety is an issue. So often what we'll do to help get patients the right help is to make sure that they get to social workers. Social workers and the hospital can access all the resources, including law enforcement. If I can identify that a patient I think is potentially being abused, then a way that I can get them help is to basically pretend that I don't know what's going on, act like I don't see any abuse, and even if there's a really kind of small need to do it, I may kind of over encourage that the patient go to the hospital out of an abundance of caution to get whatever their chief complaint or our call is assessed. And maybe I fib a little bit in the sense of maybe I exaggerate to say, maybe you need an x-ray for this. In the back of my mind, I'm not sure if they do or not, but I exaggerate a bit so that they actually just take the time to go to the hospital. I say this because when we transport patients, we can physically separate them from other people. So the patient has the right, technically, even if this is a family member, the patient always has the right to say, I don't want somebody else to know, especially if it's out of caution. And so we can utilize the HIPAA law to protect us. So if we're managing a patient that we suspect is in an abusive situation and we want to get them to social work so that this can be evaluated, do what you can to get them to the hospital without letting them and the abuser know you're on to the situation. Once it's time to transport, have the abuser, whoever they are, go in a separate vehicle to the hospital. Sometimes you can simply just say, you're going to have a car to take yourselves home when you get released. You'll probably get released pretty quickly after this, so on and so forth, assuming, again, you're pretending that this is for an x-ray or what have you, and talk them into taking a vehicle. If they absolutely refuse to take a vehicle and you think it's still safe to have them in your ambulance, you can have them sit in the front of the ambulance next to the driver, but you should never let them in the back of the compartment. In fact, most of our departments don't allow people to ride in the back with patients. But even if the patient seems like they're okay with it, try and still separate them, because maybe that's when you get your opportunity to ask the right questions to see if there is abuse going on, and certainly can put that patient in a safer situation. When you get to the hospital, make sure before the person, the suspected abuser, goes into the hospital ER with you, tell them that they need to go to the front door and go to the lobby, and someone will come in and check them in. They're probably not going to want to do that, but remind them that this is how security works and blah, blah, blah. The patient has to be checked in by themselves, and then someone will come and get the family member in a moment. So by all means, make sure that they're separate and they're not in the room with the patient when you take them into the back. Separate them and send them to the lobby. Your patient, take in and tell the person you're giving report to immediately that you think that this patient may be the victim of abuse and that the abuser came to the hospital with you and is maybe in the lobby. What they can do at that point is put a hold on this patient and with the patient's consent, not tell that person anything about the patient once they're in the lobby. Then they can get social work involved and even call law enforcement so they can do a report. You might have to give information and help write a report for law enforcement as well. So it's not absolving you of that duty. Don't just leave them at the hospital and assume everyone else can take care of it. Make sure you follow through. But again, doing this here means the patient's safe behind locked doors where there's security. So then the law enforcement conversation can actually happen. The patient gets a break from the abuser. Maybe you get a crystal clear picture of what's going on, and you did so in a safe manner. Doing that on scene is much more challenging. So I know there's a long answer for this section, but extremely important that you find ways that are safe and eventually get this patient the help that they need. Law enforcement, unfortunately, and our justice system is not a rapid means of doing so, and often not an effective means of doing so. Don't accuse people, right? That's generally going to go bad, cause an unsafe scene for you. Instead, you're going to gather information and involve law enforcement, even if it's in this long roundabout way of getting the patient to the hospital first. Sexual history is also part of that process of privacy concerns. So I'll let you read about, basically it's restating what I mentioned, excuse me. But I want to add that when patients have urinary symptoms, and they're male patients, that may be an indication of something like an STD. And so we may need to ask some more questions about sexual history in that presentation. We'll talk more about the implications and more about the specific questions you'll ask later when we get to the GIGU and the reproductive blocks, okay? Ask all patients about potential for sexually transmitted diseases. Sexually transmitted diseases need to be reported to the State Department of Health. You don't have to do much about that other than make sure it's in your chart, and then it will go through the system and be reported to the state. You don't have to take it upon yourself, but make sure we're documenting this. The state tracks it so that they can track the rate of these diseases in the community. Sometimes patients don't want to talk to you, and so that's a communication challenge by itself. And maybe they're perfectly capable of talking, but you in particular, they don't want to talk to. And so being patient with your patients and remembering that arguing with them and trying to force them or do anything to trick them into communicating with you is generally going to make things worse. And so patience, I think, really is the key to this process. Maybe they're silent for reasons that aren't about you. Maybe it's not about your rapport. Maybe it's an indication of other things going on around you that you can manage, and then the silence will break. Or in some cases, it may be their natural state. How do you tell? Ask people nearby that know this patient if this is normal behavior for the patient. Do so in a way that doesn't make the patient feel like you're talking around them. Involve them in the conversation as much as you can, but that often can tell you a little bit about their underlying demeanor and to determine whether or not this is something that's going on today. Sometimes, though, patient's silence is a clue to their chief complaint. Perhaps they can't talk because they're having a stroke, for example, among many others. If silence is present, you may employ more closed-end questions. Just know that the value of those questions is really limited, but it's better than nothing if we're working with silence. Sometimes patients are overly talkative, and so explore the reasons that they may be acting abnormal on that end of the extreme as well. Patients a lot of times have multiple symptoms, and so it sometimes is difficult to narrow it down to a specific problem that is, again, our goal is to determine what's the life threat to this patient right now and to manage that and get them to definitive care. When patients are older or they have complex medical diseases or traumatic diseases, long-lasting effects, it may be difficult for you to discern which thing is the most important today or bothering them the most or indicative of an emergency. So as you go through their complaints, try and prioritize as you would in triage. So again, the triaging idea is to say, I only have so much time, effort, resources, whatever. So I need to take all of this stuff and put it into a manageable chunk. And that generally is going to mean that it fits the resources that you are outlining. So for you, time is your main resource when you're communicating with the patient. It's usually against you, and especially emergencies. And so triage, what is the thing that's most likely to harm this patient? What's the worst of these signs and symptoms and complaints that they're giving me? And then manage them from that perspective forward. Start with the most serious and end with the least serious, a good way to put it. Anxiety is going to impact your assessment. Again, anxiety is going to impact your communication with this patient. Anxiety physically manifests itself in certain ways that are predictable, but we also have psychological anxiety that can limit communication as well. I want you to know, though, very pointedly, if you didn't know this before, anxiety is actually a physical response. It's just that we often put it into the psychological response. That's to say that when somebody is anxious, their vital signs actually change. It's not all in their head. So anxiety can be an indication itself of something else that's going on within our patient. Very often, the earliest sign of somebody going into shock, like life-threatening shock, maybe because they've lost blood or other types of shock that we'll talk about later, because they're going into shock, they're going to have a release of epinephrine. And epinephrine is likely to present itself physically with vital signs that are similar to the vital signs that a person would have if they were anxious. And so it's hard to discern if this anxiety because maybe they just got in a car accident, or are they acting this way? It's not necessarily anxiety, but they're acting this way because they're bleeding internally and going into shock. So it can be for physiologic and psychologic shock. The signs and symptoms of anxiety, again, go along with our what we call the fight or flight part of our nervous system. And so that's going to include kind of all the effects of adrenaline or epinephrine. Pallor, that's to kind of describe changes in the patient's skin color. They may be sweaty or diaphoretic. Shortness of breath, the medical term for this is dyspneic. So dyspnea is shortness of breath. Numbness in the hands and feet can occur. That can be a result of the patient being anxious and breathing too fast. Dizziness or lightheadedness can occur. So again, these things are similar to what happens when a person is in the early stages of shock, and they may not be able to recognize it yet. Anger and hostility may progress after anxiety, or they just may be angry when we arrive, but anger and hostility often go together. And so anger and hostility, number one, needs to be thought of as a scene safety issue. When managing patients that are angry, it's unrealistic for you to assume that you're always going to have a law enforcement officer to manage these things for you. So you have to really prioritize, again, your approach to these individual patients. Don't treat the patients as objects or as people that you've seen before, even in the sense of, I've seen patients in this type of situation. They're often angry. If the patient feels like you're putting them into that box, it's probably going to make them even more angry. So really try to approach them as an individual, taking into account all the aspects of what's going on. It's the worst day of their life if they call 911 in most cases, even if it's not a true emergency. And so try and place yourself into their shoes with your empathy skills. And in doing so, often that diffuses some of the anger that patients have. Now, when managing patients that are angry or hostile, the worst thing you want to do is to mirror their response. And so you want to do the opposite. You want to model the behavior you'd like them to now try to display. And so that often means you need to be calm, reassuring, and gentle in your approach. When they yell at you, resist the urge. Interestingly enough, a previous life, I worked in law enforcement, took hostage negotiation training, and a key bit of information in hostage negotiation training is that when you're negotiating, when you're talking to somebody who, whether has a hostage or is just negotiating in these situations, anyways, for like their own release, never, when you manage these patients, start yelling when they yell. Because the result of yelling, just think of your personal life, is probably more yelling. When one person's angry and they start yelling and the other person matches that with yelling, then the next person needs to one up them and gets louder. And then the next person needs to one up them. And eventually it devolves into a shouting match. And that's truly what will happen even with trained professionals if we kind of let our cool go. So again, keep your composure, speak in enough terms to at least get their attention, just loud enough so that they still hear you speak, but maybe they need to quiet themselves down to actually hear what you're saying. That's actually a skill. That's part of what you're trying to do. Friends, family, and bystanders might be able to help with this, but it also might be them that the rage is coming from. And again, mob mentality often devolves into unsafe situations. If the scene is not safe or secured, make sure you get it secured by some means. If that means that the best thing for you to do is to leave that scene and have someone else like law enforcement come and defuse and then return, then do that. Again, it's not abandonment as long as we intended on going back to the patient. In some cases, though, I just hate to tell you, the reality is you may be in situations where calling law enforcement and escaping are not options to you. And so remember, you need to survive. We don't want to harm people, so we're not in our offensive mode, but we need to be in defensive mode because at the end of the day, you still need to go home to your family. That's what's most important. So I hope that you're not in situations where you have to fight for your life, but it may be something that you look into, maybe taking more training on personal defense and so on, because there will be times when, unfortunately, things happen that you least expect. I guess that's all. I'll leave it. Sometimes anger and hostility is associated with intoxication as well. And so patients are emotionally unreliable when they're intoxicated. And so they can go from extreme to extreme. So be very careful, again, thinking about scene safety wise as well. So again, potential violence, physical confrontation is high when patients are intoxicated. When we have patients that are intoxicated, don't put them into a corner. This is really helpful when patients aren't intoxicated and they're angry and hostile as well, but don't make them feel like they're being boxed into a corner. Give them as many choices, even if those choices are small and maybe even meaningless to what you're trying to do. Make them feel involved in the process. Although they're intoxicated, feeling involved gives them a little bit more control in a situation that they are probably realizing in some cases they don't have any control over because of their intoxication. Alcohol is going to dull patients' senses, and so alcohol and other drugs, this is a little caveat for later. If it dulls their senses, it means they may not feel pain appropriately and they may not be able to feel things happening in their body as you or I would not intoxicated, or that person would not intoxicated. So if a patient's intoxicated, it makes some of their information maybe somewhat unreliable. That's to say that if I have a patient, for example, more on this later, but in a car accident, excuse me, and they're intoxicated, if I ask them if they have pain anywhere, and I'm trying to determine whether or not maybe there's a potential for them to have serious internal bleeding, if they say they don't have pain, I can't just accept that because it's likely that they are not feeling, if they do have pain, they're not feeling it because of the dulled senses from their intoxication. So it's not just alcohol, but obviously this is a big part of the calls that we go on, unfortunately. And so in those cases, I'm going to have to defer to maybe needing more advanced studies, like actually taking the patient to the hospital to be evaluated with things that can look into the body, since I can't rely on what they're telling me to make my assessment decisions. Okay, more on that a bit later. Crying, I'm going to leave for you to read, but there's just two things about it, not necessarily on this slide, that I want to mention. So when patients are crying, again, it may be an indication that their airway is open. So I wanted to remind us that that's part of our airway assessment. We can often note patient is crying as a support in our chart that the patient's airway was open. Obviously, make sure you follow that through with a good assessment. The other thing is, you may hear later in pediatrics people say that if a baby is crying, they're okay. So I want you to kind of just put that in the right context. If a baby's crying, they're definitely not okay. If they're small children, like infants, they only cry when they really need something. And that's the only way they can communicate it, right? An infant can't say that they're poo-poo. They can't say that they're too hot, too cold, or hungry, or hurting. And so their response is always to cry. So when a child is crying, when we say that it means they're okay, what we're trying to say is, if the child is crying, as scary as the situation may be with children, because we don't see them very often and we're going to feel maybe not ready to take these calls, maybe for our entire career feel that way, but in the presence of children, their crying can make you, certainly make frustrated and make you think that things may be going on. The crying itself, yeah, it's for a reason, but it does mean that if they're crying, they're breathing, they have an airway that's open, and they do have perfusion to their brain, at least to the level that's allowing them to perceive what's going on and give a response of a cry out of it. Okay, so that's a person with, not great, not perfect, not totally healthy, but pretty good vital signs to start with. So don't let crying be an indication as to how sick they are, because if they're not crying, that may be the problem, because they're too sick to cry, they're unconscious, they don't have enough air in their lungs to cry. Those are ominous signs. So if they're not crying, we're a little more scared of that than they are if they are crying. Excuse me, but never forget to investigate that. If the patient's crying, try and figure out what that is. It's hard to tell, again, for a variety of reasons. And so if you have a child, an infant that doesn't have any caregivers nearby, hopefully you've got access to some diapers. Try changing the diaper. If change the diaper and they're, poopy, that might alleviate the crying. But often ask the family around them, because they may know, one, what the baby's in need of because they've been with the baby for the day, or two, they may recognize the different type of cries. Children will cry, especially very relevant to the family member that's with them all the time. They cry differently when they're in pain than when they're hungry, than when they're poo-poo sometimes. And so they may just know what that cry means as well. All right, good stuff. Depression is an important component of a patient's overall mental health. And so depression itself could be the disease that you're responding to, and they have signs and symptoms of that, or maybe depression and suicidal ideations. When managing patients that have depression as a chief complaint, we're going to be describing those components of it when we get to the behavioral health section of the textbook. So for right now, we're just kind of thinking of it as a challenge in discussing and managing our patients. And so there are things that we'll consider outside of this. This is just kind of an approach to managing or communicating with patients in these situations. So depression is very widely experienced, unfortunately. Antidepressants are some of the most commonly prescribed medications in the world. Patients often have at least an experience with depression, just as all of us may have an experience with depression. Depression clinically has a diagnosis and some parameters for it, but the feeling of depression, I think people can appreciate. The severity of it is what maybe steps out of the bounds of normal experience. When patients are severely depressed, obviously sadness is one part of it, but they feel hopeless and like there's no resolution that can come from anything that they're going to be able to contribute to whatever it is in their life they're worried about. And certainly we all have challenges, some challenges worse than others, but the individual person, their challenges are for themselves to judge and put importance on. So as we approach patients that are depressed, try not to minimize or to compare themselves to you, and again, approach them as an individual patient with empathy, trying to fit yourself into their shoes and understand the best you can what they're going through. Associated with it may be some irritability. They may have sleeping and eating disorders, and obviously a decreased energy level. And sometimes patients will have this depression state and then swing into the opposite, or a manic or very elevated state. The best advice I have for managing patients that have any type of psychological emergency as you're managing them, certainly other things to consider like physical responses and consequences of their psychological condition, and certainly scene safety issues and all of those things aside, which we'll discuss later. Generally, just listening to your patient. And if they want to talk, you listen. If they don't want to talk, then don't pry too much. Get what you need to do your job, but lend yourself, making yourself open so that they can feel like they talk to you. Maybe they don't right away, but maybe they will later. And again, as we mentioned in therapeutic communication, that may be the treatment in itself. Patients may have a variety of reasons for them to be confused or to have behavior that is abnormal and confusing to us when we view it as well. And so consider when patients present that way, all the reasons that they may have that altered mentation. Often, though, when we're in the field and we've been working a while, we tend to associate that behavior as an initial response to them being intoxicated or some other non-emergent situation. So the catch here is that many emergencies that are true life-threatening emergencies resulting in death mimic typical alcohol intoxication. Not necessarily the severe, stumbling drunkard, though that's present in these cases. Even just slurred speech, something that is easily associated with alcohol intoxication, may be by itself an indication exclusively of a disease, and the patient doesn't drink any alcohol whatsoever. So try to stay away from that initial assumption. If that's what we're left with, great. But if we just go to it, we're going to miss all the other things that could be going on. So those conditions include things like hypoxia. So anything that causes the brain to go with low oxygen is going to result in abnormal behavior because the brain won't be able to function. So hypoxia can come from strokes, diabetes, though diabetes may be also a lack of glucose going to the brain, so the brain can't do its metabolism, as we talked about previously, can't create energy. No energy, brain isn't going to work. Trauma often results in hypoxia. Medication, so intoxication, obviously, prescribed and otherwise, medications that they take accidentally that cause them to be intoxicated, and those that they take purposely as well. These things can lead to changes in the patient's behavior, and often, especially with some of the drugs that patients abuse, we may find certain behaviors tend to be associated with certain drugs. Again, that may be true, but there are other behaviors that are more severe and life-threatening, perhaps in that moment in time, than kind of are treating someone as if they're an alcoholic or a druggie. That generally comes with less assessment and less care because we're burned out about it and we make assumptions. And that often will result in a high liability miss on our part. Patients may also have confusing behavior because of underlying psychological, either structural components of their brain are not functioning well, or they have psychological emergencies that cloud their experience. So some terms for us here: dementia versus delirium. So those two terms we're going to compare and contrast when we get into the behavioral emergencies later. Dementia is generally associated with forgetfulness and often has a slower kind of over time progressive process of getting worse. Delirium, though, is a break with reality. So it's in its own little box. So think break with reality may mean hallucinations, and these are often abrupt or acute instances. Often patients that are experiencing dementia are experiencing something that's likely not reversible. So this is maybe thinking along the lines of something like Alzheimer's disease. Delirium, on the other hand, is often associated, though it could be associated with those long-term non-reversible psychological diseases or structural brain diseases. Delirium can be the result of acute intoxication, an imbalance in electrolytes in the body, a variety of those things that all kind of lead to the brain not functioning well. Some patients have limited cognitive ability, so this becomes a risk for us when we're kind of describing the process of consent here. So to throw it way back to a few weeks ago, in MedLegal, consent is based on autonomy. And in the United States and most Western countries, a person, well, most countries in the world, I would imagine, but most Western countries, based upon kind of the same morals and ethics that are spread throughout Western countries, include the idea that you should have the ability to make decisions for yourself, including medical decisions for yourself. So that's autonomy. So that means that patients have to give consent to what we want to do to them. Now, we had a few different types of consent. We had informed, right? So that means I talked to my patient, they understood what I was telling them, so good communication happened, they interpreted it, and then they could make a decision based on that. And that decision hopefully was express consent. So that's the gold standard. We want to inform our consumers and then have them tell us what they'd like us to do to the best of their ability. Sometimes, though, patients don't have the ability to receive the message, process the message, and make sound medical decisions off of it because of some underlying cognitive disability or a limited cognitive ability. Now, when that happens, we often can't inform them, or if we inform them, they can't make their express consent. And so a more risky type of consent is implied consent. So when managing patients of this sort, we have to keep that in mind because it may mean that though they may request one thing, we're obligated to then do something that we would do for someone who would give consent. So kind of our prototypical patient allowing us to do our prototypical treatment. These patients may be developmentally handicapped. There's a variety of reasons that they may be in the position that they're in. They may have been born that way. They may have suffered an injury in their life that took them from a normally functioning person to now someone who has limited cognitive ability. That might be a traumatic event and so on. So there's a lot of nuance in who these people actually are, because they still are people, though we limit some of their decisions, unfortunately. Keep your questions simple and limit the use of medical terms very, very drastically. And so we're not likely going to use like terms that are associated with names of diseases. We have to describe it a little bit more than we use those terms. Rely on the family, though. These patients often will have present with them, though not always, unfortunately. These patients may have people with them that are their guardian, their legal guardian, their parent, or their caretaker. And often those people know how to communicate with them. They know how to manage the patient in situations where maybe the patient isn't acting physically appropriately, and they'll know how to best meet that patient's needs, hopefully with the patient's best interest in mind. Cultural challenges, we can expand on. They're a big component of our communication, which by nature makes them part of assessment, but it also impacts our physical assessment and treatment as well. So I'm going to use just a very general example. So again, every culture has subcultures. We have a pretty large community of Middle Eastern recent immigrants in the Albuquerque area, certainly also in other parts of the state as well. And within some of those people, the cultural standard is that a male provider that's not related to the female patient cannot physically assess that patient. And so, in the world of that cultural consideration being met, it would mean that the only male that can touch or be with that patient is a family member. The non-family member that would assess this patient physically would have to then be a female. And again, meeting that challenge can be very difficult because the predominant portion of our industry is still male dominated, in the sense of that's who's on more trucks in more jurisdictions. And in some jurisdictions, there isn't someone else to call that's reasonable. And so trying to communicate with your patient so that you can attain the same assessment goals, and maybe you'll prioritize some over others to do now versus let a female provider do in the hospital. So there's a wide variety of these considerations that you have to take into account. And again, always ask first, involve consent, and seek to know your patient's views on things, the world, what they consider right and wrong in the sense of how they want to be treated as a patient. And you'll hopefully in that time be able to learn how to best meet their needs. If patients need translation, there's, for most services, translation available. It just takes a moment. You're usually doing it over the phone, but it may be something that's done with technology on FaceTime or something of that nature. But there is now the ability in most jurisdictions in the pre-hospital setting to basically get a translator for virtually any language, not just the local dialects that somebody might be on duty for. Gain the assistance of patients' family members. Again, if you think of communicating with a family that maybe has different cultural considerations, but maybe speaks a different language as well, if you're assessing an older patient or a parent, it may be that you're communicating with the children as they learn English in American schools. And so recruit the resources you have on scene to the best of your ability as well. Hearing problems, a note here will come up in geriatric assessment tools later when we get to special patient populations. And so one of the challenges with patients that have low or complete hearing loss is communicating with them and doing so in the appropriate way, because there's a wide variety of hearing loss. There's different degrees of hearing loss that patients experience, and many patients may have some hearing loss but wear a hearing aid that almost completely corrects it. So when managing patients with hearing problems, seek to see what they need and give that to them. But in general, again, these are all generalizations that you'll have to manage for now. Ask questions slowly and clearly and enunciate so that the person, if they're going to read your lips, they can do so. Face the patient and, stop doing what you're doing otherwise so that they can see you face to face within proximity and read your lips. And sometimes that takes a little extra thought on our end to slow down and do. Use a stethoscope if they need that as a hearing aid. So basically put the stethoscope in their ears like you would for yours, and then kind of gently speak into the stethoscope. Great idea. Be careful though, because it can get pretty loud, and then simply just clean it with alcohol and cavi wipes afterwards, and that should prepare it. Or use, the ambulance stethoscope instead of your own. Learn simple sign language, or carry a reference chart with you so that you can use it to help learn or just use on the spot sign language if that person utilizes it. And then certainly if they can see and they have motor function and they're awake, then recruit the use of their writing skills to help you as well. Don't be afraid to write so that they can see, and they'll probably verbally answer back as well. Never just start speaking louder, again, because it may be that that's not going to solve the problem, and often that frustrates them if they're trying to read your lips a bit. And certainly if patients have hearing aids, ask about it. Maybe they forgot to put it in, they don't have it in. Certainly ask about that before you transport so that you can take things like dentures and hearing aids with you to the hospital. All right, lots of little nuances and details here, right, that you're definitely going to want to use in the field. Visual impairment might be a little bit more difficult. They may hear just fine. So verbal descriptions then become more important, and speaking very precisely and clearly to tell them things that maybe you would just benefit from them seeing and you not even having to mention if they did have their eyesight. And again, eyesight may be variable. Get a baseline, ask what they normally can see and what that change is now to see if it's relevant for their assessment and physical symptoms. When managing patients that are blind, their only interaction obviously with us is likely going to be obviously touch, but first interaction is going to be through sound. And so before we touch them, we want to announce our presence and again, tell them maybe what to do while we approach them. So a good example of this might be a patient that's been in a car accident. Maybe their cervical spine is injured. We haven't assessed them yet. We're walking up. We suspect that's possible. If we speak to somebody, even if they're not blind or visually impaired, they're going to turn their head to look at us in the normal kind of cultural procedure and then speak to us. You're going to want to inform them initially, before you even tell them much else, that please don't move your head when I'm talking to you. Keep it straight until I can assess your neck. And again, that's before you touch them. But that telling them that verbally is extremely important, but takes that description of you to get met. And then once you're there with patients that are visually impaired, especially tell them about movements that you're going to be doing. So if you're going to have to move this patient from the floor to a gurney to the ambulance, walk them through before you move them these things, because it can be really startling to just suddenly be picked up off the floor and put onto a gurney. Secondary assessment, again, includes these challenges and then some more tools in addition to sample and PQRSTU. So the whole goal with the secondary assessment, time permitting, is to say that if you had all the time in the world with this patient and it didn't matter whether or not you treated them for whatever reason, the gold standard, your best assessment would be to give a full, thorough assessment of all of their body systems and all their body regions, and make sure that nothing is wrong with them whatsoever. And I say that, it's a big ask, but that's, again, time permitting. I say that because we may see patients when they don't have medical providers in their lives or haven't gone to and won't go to another medical provider for some time. And so it's not uncommon for a good EMT to be paying attention in their assessment, find some other thing going on with this patient that definitely needs to be assessed at the hospital, but is maybe not necessarily what's related to the patient's chief complaint. That may save patients' lives literally in situations where maybe you didn't feel like you or didn't use your tools to do so otherwise. And so your physical assessment should aim to be as thorough as possible, not the minimum. The minimum is what we do when we're pressed for time and we don't have the resources we need, and we need to get X, Y, and Z done. Okay, so those times we may only get through airway and breathing because we never fixed airway or breathing in our entire transport of the call. But that's not what we're seeking to do. So please don't be a minimalist here. Seek to do a very, very thorough assessment and know about their entire overall health. Okay, so when we're doing this in patient care, secondary assessment is in depth, right? And it may be personalized for that individual patient, whereas our primary assessment was not. It's the same for every patient. They all get ABCs. Where we perform this depends on whether this was load and go and stay and play. So if we perform this on scene, it means that we're taking time, not transporting. So that needs to be a conscious decision of yours, and one that you made because this patient can wait. If we're doing the secondary assessment in a load and go, we're going to be doing it in the back of the ambulance, en route to the hospital, or in some cases, not at all. So what I mean by this is the rare case that you never get past your primary assessment because you spent all of your time treating one of the ABCs. So if I'm managing a patient and their airway just keeps failing and the entire 10 minutes that I have to transport them to the hospital, I never even really get to assess their circulation beyond making sure they had a pulse. That would be acceptable in the instance of I never really fixed their airway problem and I tried all my time to do so. Would not be acceptable though if you have a patient that doesn't have any of those life-threatening issues. So not at all is reserved for only when you physically could not get to it because you're, saving the patient's life. This should be systematic as it will be charted systematic. So you need to have a very clear organization to doing so. So we seek to give that to you by giving you essentially the head to toe assessment. Now I keep referencing this. You're going to read the head to toe organized assessment in your textbook, but you're also going to see it listed in your assessment guide for trauma in lab in your treatment guidelines. So that should tell you how to do a very thorough head to toe in the process. So I'm going to give you some pointers as we go, but not necessarily give you those stepwise procedures that you're going to want to follow by looking at the lab documents. So what do we do? Well, we're going to utilize a few different tools. Now, we probably use these earlier, so we just throw them in here now. But at any time, if you use some of your personal tools to assess a patient, tools among your senses, inspection is the process of looking at your patient, so getting eyes on them. That's the process of inspection. Palpation was to touch them, so we palpate a radial heart rate when we count it. Auscultation is the use of hearing. So the use of hearing generally for us means we're utilizing something like our stethoscope to either get a blood pressure or to listen to lung sounds. And when we're using those tools on our head to toe and secondary assessment, the things we're looking for are known as the acronym DCAP BTLS. So the way I'd like you to use this, and obviously memorizing, and certainly you've got a term here for each one of these, is to think to yourself, when I start my head to toe assessment, I'm going to be going through every part of the body, but as I go through every part, what I'm really looking for at every stop is DCAP and BTLS. So I'm always looking for deformities, contusions, abrasions, punctures, burns, tenderness, laceration, and swelling. That's the thing you're looking for when you're assessing a patient for a head to toe. And that's whether or not they have trauma. You don't necessarily know what's going on in the case of using all of this. You're trying to figure that out. And so being very thorough means you're looking for all of these in each portion of your head to toe. Let me give you some definitions here. So deformities just means that you have some abnormal formation. That could mean that they have a broken arm that looks like an S now instead of an L. That would qualify as a deformity. Contusions are essentially the equivalent of a patient having some broken blood vessels under their skin. And more commonly, we might call this bruising. And so there's discoloration involved as blood leaves blood vessels but stays within the skin. Abrasions are the removal of parts of your skin. So often that's going to be the removal of the surface layer of your skin, exposing the tissue underneath. Think of something like a road rash, for example, for abrasions. Punctures and penetrations, these are stab wounds, puncture wounds, shootings, all of those things would qualify. Burns are either thermal or chemical, but they're a burn to a portion of the patient's body. Often that will come with some physical damage to the skin when present. Tenderness is not necessarily something you visually will see, but it's when you're palpating the patient, you're touching their physical body to elicit pain in areas where it's tender. This is something you're going to find as you actually palpate the body. So when we do a thorough head to toe, we will palpate the entire body as we go through region. And so if we note that the patient has pain or winces or is tender somewhere, we're going to chart that and think of its relevance to our patient's underlying condition. Lacerations are essentially forms of cuts that may extend all the way through down into the bone and the body cavities. And then swelling, the medical term for this is edema. Swelling may be because of an accumulation of fluid or blood in an area that pushes the tissue. So swelling generally we can see visually or we can feel. Okay, so the systematic approach basically then is to go through the entire body from top to bottom, front and back, and do this in about 90 seconds, checking for all of those things as you go, okay? So you're gonna think of DCAP BTLS essentially every time you move. I don't know that you need to go through it each time until you've essentially memorized it, and then you'll be able to just kind of hang on to it. So at that point, then, when you have it memorized, when you do a scenario, you're going to tell your proctor, I'm going to perform a head to toe, and I'm going to do so to look for DCAP BTLS. Usually they'll understand. If they want to explain, you'll have it memorized. And then as you go through, you don't say that again. That's so you can expedite this process. So what I mean by that is, imagine you're standing basically at the head of the patient. They're laying supine in front of you. Their feet would be pointing away from you, their head pointing towards you, and you have your hands on their head. So you're going to start at their head, and you're going to start by essentially feeling and pressing on the skull, the face bones, the neck. You're going to feel all of those areas. And each time you go to those areas, you are looking for DCAP BTLS, but you'll just state it once. All right, hopefully that helps. Now, focused assessment's a little bit different. The systematic head to toe is thorough, so it's not going to be focusing in on any one area. It's meant to find everything that you could have wrong with the patient. This will be performed on patients as a focused assessment when we're really trying to narrow down to a particular region of the body that's injured or a particular organ system that we may be suspecting is ill. And so a focused assessment can be very helpful, especially when you don't have the time to do a thorough head to toe yet. You're still kind of working out how bad is the injury or this area that I found on the patient and exploring it. So it may be an injury, but it could also be alluding to an organ system that's ill. This will often follow with their chief complaint and then what we think is wrong with the patient. That's the area that we'll investigate. We're going to focus our attention by basically either asking more questions about how that system works. So for example, if I'm focusing on the patient's GI system, because I think that's where their illness or injury is, I'm going to start asking questions about how their bathroom trips have been. Do they have diarrhea? Do they have any pain when they go to the bathroom? Have they been having problems when they're eating? Do they have any nausea that occurs? Do they have ulcers? I'm going to maybe assess the patient's abdomen more thoroughly. And so you kind of dive into that area that you need to know more about relative to what you think is wrong with this patient. So the systematic review, the head to toe, that's where I want to go with everything. But to quickly get to maybe determining if this is a life threat, I may have to go through a focused assessment. The next few slides is going to outline in our focused assessment the particular things that you're going to look for in each system. And I do want to kind of cover these, but I'm not going to read each bullet point as we go. So for the respiratory system in our focused assessment, I need to add that this is secondary, right? This is secondary assessment. Lung sounds, listen to breath sounds. Lung sounds are auscultated. You listen to them. You're going to listen to lung sounds in your secondary assessment in all patients. That's your goal. If you didn't do it in your primary. So why did we listen to lung sounds in the primary assessment? The reason was they had a problem with breathing, so their work of breathing was abnormal, or they had a pain or discomfort or complaint that involved the neck, the chest, or the high abdomen. all around the idea that if there's a problem that they're complaining of there, listening to the lung sounds will actually help you narrow down exactly what's going on with your patient. So if you didn't do that in the primary assessment, then you're obligated to do it as part of your respiratory system secondary assessment later on. Thankfully, if you memorize this with your head to toe, when you get to chest, say, I need to listen to lung sounds, practice that on the mannequin in lab, it'll be much easier for you to always do it in the secondary, and then sometimes you'll have to do it in the primary. If you always do it in your secondary, that's your backup, so that in your scenario, you'll find any problems with the lung sounds that you maybe missed otherwise. All right, let's see. These are all fine. We've talked about. We did a little bit of this in the primary assessment, so not much of those things go away. You're still assessing for them. How to assess the lung sounds we talked a little bit about. I've defined these abnormal ventilatory sounds. Cardiovascular system, look for trauma to the chest. We didn't discuss that yet. That might be that they have bruising to their chest from recently having played a game or some other type of injury that they didn't otherwise tell you about, especially helpful when you have patients that are unconscious and you don't know if that's the case that happened beforehand. Blood pressure, again, kind of looking at primary and secondary. If you're going to get a blood pressure on a patient, it's often going to be in your secondary, okay? So then there's parameters to do a blood pressure in the primary. If I'm going to have to give my patient a medication pretty rapidly, and I'm going to be likely on scene doing this, then I'll probably take a blood pressure in my primary on scene. But if I have a patient that is really sick, and let's say is a trauma patient, and I know that they don't have a good blood pressure because of their other vital signs, lack of perfusion, they don't have a radial strong pulse, any of those things, I'll get a blood pressure, but it's going to take time to do so. So I don't want to take my time on scene to get a blood pressure in trauma or really sick patients unless I need to know it so I can give them medication. When we have patients that are in those traumatic incidents where they're bleeding internally and their blood pressure is really low, often we don't have a medication we'll be giving them. Getting them to the hospital is the priority. So in that case, we can get a blood pressure en route, knowing that I know that they're already sick. I'll figure out how sick they are when I get to my secondary assessment. Hopefully that helps, because that in practice will be a very important part of your lab tool. In fact, doing this on scene or not on scene comes back to the 10-minute rule of trying to get off scene with critical patients in less than 10 minutes. If you do a blood pressure, you're going to take a few minutes to do that. That may be some time that you could better spend just doing a blood pressure in the ambulance while you're driving down the road. All right. I know I kicked that around a few times, but it's commonly missed, unfortunately. So just trying to save you some time before you get to having to memorize that and perform it. Okay, vital signs, I'll let you read through. You've got, we discussed these already. You've got lists of these things already. Blood pressure we didn't talk a whole lot about, so let me help kind of just describe it. Blood pressure by itself is a fraction, so there's two measurements. You're going to practice this in lab, so I'll let you get the procedures. A blood pressure can be palpated or auscultated. We want to auscultate it. Ding, ding, ding. That's the number one choice. So that's our goal. We can palpate it if we're in circumstances where we can't listen for some reason to their blood pressure. It's less accurate and gives us less information. So auscultated is our number one goal. So that's how I'm going to describe our findings first. So normal blood pressure is 120/80. The top number is the systolic value. The bottom number is the diastolic, all testable. The top number represents the pressure wave that the heart creates when it squeezes and sends blood into the body. So what you're measuring here, essentially, with your systolic, or the top part of your blood pressure, is going to be equivalent to the pulse wave. So remember, we mentioned that when you feel a pulse, you're going to feel pressure. If you have a pulse that's at a distal point, like the radial artery, then it's got enough pressure to get to that point, which means it's high enough pressure to get to the brain. If we don't have a distal pulse, we start to worry about whether or not there's enough blood pressure to get to the brain. So that's kind of the idea behind the systolic portion here. When you take a blood pressure, the top number is the physical value of pressure that the pulse you felt represents. So that's how those two things are correlated. The diastolic, we don't spend a whole lot of time describing, talking about using in the same way as we do our systolic. Some of our medications are going to be based on systolic values and not necessarily the diastolic. The diastolic is basically the pressure that's inside the body in between each pulse wave. So every time you feel a pulse, that's a ventricle squeezing. In between, basically your heart fills with blood so that it can squeeze again and create the next pulse. So in between each beat, the diastolic value is the measurement of how high the pressure in your system is. Similar to the idea that your house always has pressure in the pipes. When you turn the water on, it just flows, but it's already there because the house is pressurized through either well or, city water. And so that standing pressure in the pipes of the house is basically the diastolic pressure. The higher that standing pressure is, the worse medical problems will be for arteries because it causes problems by really stretching out and stressing arteries. It can also stress out and stretch the heart. So when we see the diastolic value, we're most concerned when we see it going up because that means the cardiovascular system is more stressed because it has bulging pressure inside of it relative to what its normal pressure would be. Kind of like if you got a surge of pressure in your house and your pipes are only rated for a certain pressure. If that pressure wave that comes into the house is too high, it'll burst your pipes. We can have similar diseases that are a result in the body if the blood pressure, especially the diastolic over long periods of time, but even the systolic, if it goes too high, that can be the result, unfortunately. So we're very concerned about the blood pressure, but again, this tells us a precise measurement of something we're likely already going to know. This is all talking about perfusion. Okay. So I want you to know the reason why we don't do the blood pressure on the scene with an ambulance very clearly. When we have a patient that maybe is in trauma shock and we need to get off scene with rapidly. So we can measure perfusion in a few ways. We have already through the primary assessment discussion. So measurements of perfusion included the heart rate, pressure, right? How strong is the heart rate? Where we found the heart rate, so location. The patient's LOC represents to a degree how well they're perfusing. If their LOC is decreased, it may mean that their blood pressure is decreased. So we already see the effects of it before we know the number. And the effects are really what we're concerned about because that's going to be the first thing we noticed in our assessment for us to determine, okay, let's fix that by restoring perfusion and giving oxygen to the patient. We also got this from skin color, right? When patients have pink skin, it means that they have enough pressure in the system to feed everything. And so the skin can get a little bit of oxygen and blood as well because the brain is getting it. But when the brain and the heart and the lungs stop getting it for some reason, we draw blood away from the extremities, away from the skin, creates really generally initially pale color, and then progresses to cyanosis. And that's an indication of their perfusion status. So again, you have the tools already to know what their perfusion status is. The goal is the perfusion status adequate, like for their brain? If it's not, we intervene rapidly. And if that intervention is at the hospital, we get off scene rapidly to get there. I do want to get a good blood pressure on my patients, even those that are in shock and trauma, but I want to make sure that I don't take the extra time that it takes to take a blood pressure. And sometimes we don't always get it when we take it, to unfortunately result in delaying our scene time and ultimately not getting the patient to the help they deserve in time. All right, good stuff. I'll let you go through the steps of assessing blood pressure. The neurologic system is worth discussing, one of our big three. And so obviously we've talked about things like GCS, AVPU, which is part of GCS. You'll reassess that in your focused assessment as well as when you do your reassessment. And then other things that we can see that are changes in the neurological system functioning normally, aside from changes in mental status, are indications that the patient has a head injury. We'll talk about the signs and symptoms a little bit later. The patient being in a stupor, so essentially similar to being drunk, but not drunk, if you will. So that kind of ataxic or shuffled, meandering movement, but very slow, maybe a little discoordinated. Dizziness and drowsiness may be an indication. Syncope basically means that the patient had an instance in which they fainted and technically they lost consciousness when they did so. When evaluating the neurological system, we evaluate the brain and the spinal cord as the central nervous system, but we also assess the peripheral nervous system, meaning we're assessing sometimes the nerves that are connected to their bones and muscles and in their skin as well. And so part of the focused assessment may be that you're assessing the patient's central nervous system for a stroke. We may treat that as one type of assessment, or we're doing a very focused assessment in the sense of trying to determine whether or not the patient can feel their legs to see if maybe they have a spinal cord injury or they have a severed nerve in their leg from a isolated leg injury. And so there's a variety of reasons to do the neurological exam and components of it. So if we're assessing the patient's level of consciousness and function of their brain, then we're clearly trying to assess their central nervous system. We'll give us other means to do the assessment of their extremities and other things a little bit later. The nervous system includes the control of the muscles around the opening of your eye. And so the pupils, opening of our eye, is a really important tool. We say that this is basically the window into the brain. Because our findings in pupil assessment, just simply shining a light in somebody's eye and seeing how quickly the muscles constrict and then dilate afterwards and so on, comparing those between each eye, that can tell us about the functioning of the brain and can tell us early about the presence of some severe brain disorders as well. So assessing patients' pupils is essential, and I would recommend that. Again, this is a tool that we can use in primary assessment and in secondary assessment. When will I check pupils in a primary assessment? Any decrease or change in level of consciousness, I'm going to check pupils right off the bat, because maybe the pupils will tell me right away why they have a change in level of consciousness. I'll also assess pupils in the primary assessment in patients that maybe don't have a change in level of consciousness, but maybe will soon. So things like traumatic brain injury or TBI. Maybe they've suffered a head injury from a car accident, and I'm trying to assess whether they're going the route of potentially having an injury and having, unfortunately, a decrease in level of consciousness. If I didn't assess it in these situations, and again, there's a variety of reasons for a decreased level of consciousness, I just say all of them, then I'm going to assess this in the secondary. And I'm going to do this when I do my head to toe, starting at the head. All right, so what am I looking for? The procedure, I'll let you review and practice in lab, but you're shining a light on the edge of the eye. That should cause the pupil to constrict, and it should constrict in a circle evenly around. That should be equal in both eyes when you do it to one eye and then following in the other eye. If they're not the same size or they don't react the same way, maybe one changes, one does not, that's definitely notable and probably indicates that they have something wrong in their brain. It may be that their pupils don't respond at all, might be indicating that the patient has severe brain damage or perhaps is even deceased. Sometimes the patient's eyes will respond really slowly when you shine the light instead of rapidly, which is what's supposed to happen. That can indicate things like intoxication or, as mentioned, other diseases mimic that, including things like patients having problems with their glucose level. There's some pictures of pupils. So this is the normal response, essentially. They're both about the same size, assuming that they got to that size pretty rapidly. This patient's pupils are dilated, so the opposite of being constricted. And this patient has unequal pupils. The dilated pupils may be an indication of hypoxia or drug use. The unequal pupils may indicate a stroke or traumatic brain injury. There's a small portion of the population, I think it's like 10 to 20% of the population, so that's a big enough number to see patients that have it, have this condition called anoscorgia. And anoscorgia is basically a normal condition in which the patient's pupils are unequal. Often patients will know that they have this, but they won't necessarily know to tell you about it. So you want to ask the patients, if you do see unequal pupils, if that's normal for them, and then from there determine whether or not it's a clinical and significant finding. Outside of that population, it's abnormal if the patient has unequal pupils and probably indicates one of these things going on, which are all not good for your patient. Normal finding for pupils is that the finding is pupils are Pearl, and Pearl is actually an acronym, so make sure that you spell it appropriately for what you mean. So instead of normally writing just what Pearl is with one R here on this line, otherwise it'd be about the same, you're writing that the pupils normally should be pupils equal and round, rectangular, regular in size rather, and react to light. So that should be the normal finding. If it's abnormal, we can't write Pearl. Pearl would be to convey that nothing's wrong with them. Okay, so in the next set of slides, which most I'm going to let you read, it basically goes through each portion of the body and describes the things that you should do to do your head to toe. So again, this is procedure. So I want to tell you what you're going to do with it, and I'm going to send you then to go and memorize it yourself. This will be best utilized in conjunction with practicing it in lab or even just on a pillow at your house, all right? So what you're doing here is essentially the head to toe. This is technically tested on in your lab as part of your trauma patient assessment. So there's a sheet for it and a procedure guideline. So make sure you look that up. When you're going through this, again, at each region in your head, you're just basically thinking that you are looking for decap BTLS. To your proctor, I want you to say before you do a head to toe, as you're palpating the head, say, I'm going to assess this patient performing a head to toe. I'm going to look for decap BTLS at each point, though I'm not going to say it. And that should be understood. If they need to describe decap BTLS and have it memorized, describe it. But it basically is all the things that you're inspecting and with your eyes and palpating with your hands for in your patient when you perform the head to toe. Okay. So these are going to outline areas that you should assess. Some of these will come with pictures in your textbook that I highly encourage you to look at. As you go through, I want you to actually visualize, okay, close your eyes and imagine how you do this thing. And if you do it once on a person, it's then, a lot easier for you to visualize it afterwards. But this needs to be part of your memorization, sitting down with no one around, closing your eyes and thinking in your head, this is what I'm going to do. Visualize it as you learn that skill sheet. That's your highest chance of preparation for success on that test, is to have it visualized so that when you go and perform it, it's already part of your motor skills, essentially. If you just memorize steps and don't visualize, you're missing a big component that will help and shorten and make your memorization of that skill more effective. All right, team, lots of information, a little worn out, but we have gotten through everything we need to for right now. You're going to look through the rest of the focus assessment. There's some more discussion about secondary as you move through, but I think you have the core nuts and bolts. Now, I don't expect that all the things that I told you on these slides are going to be immediately testable, though many of them are, especially the things I took time to elaborate on, but they're all 100% useful for you in lab right now. In fact, when you go and do your assessment in the clinical setting, when you're in the hospital or on the ambulance, you'll be using and thinking of these things. So this is essentially how you open the door to what's wrong with your patient. Once you have a great assessment technique, all the other stuff is going to come much easier, because once you can give a name to the thing that's wrong with this patient, it's much easier to identify a treatment plan, figure out which medications you're going to give, and then go through steps of executing them. Okay, so definitely probably overwhelming, but we're giving you all the tools you need for a thorough, full assessment of any patient. And then anything below that to accommodate your patient's needs is going to be easier. Okay. All right, team, let me know if you have any questions. I'll get this posted as soon as possible, and that concludes our patient assessment. All right, take care. Have fun in lab.